Hello students, this is Lamunyon. This video is about my experience in research and nursing research. Firstly, one of the most important credentials that I have is an undergraduate degree in research psychology. This is not nursing research, however, nursing uses the APA format, the format from the American Psychological Association. I want to talk about my early research. The first project that I did was what I called Attitudes on Relapse and Reporting. At this time, I was working in addiction care and a consultant to the California Board of Registered Nurses for developing a diversion program for nurses with alcohol, drug, and mental health problems. The program was set up so that there would be frequent monitoring, urine testing, and participation in treatment, and after treatment, aftercare, outpatient type follow-up, including a nurse support group. After the program began, the Board of Registered Nurses wanted the facilitators of the group to report any relapses, that is, any episodes of alcohol or drug use. Now, you may recall that confidentiality is very important, and this would be a breach of confidentiality. So the group that I was aligned with wanted very much to not turn the support groups into report groups. So we did survey and found out, verifying our initial thought that yes, it would have a chilling effect. Nurses would not feel safe to discuss their problems, fearing it be reported to the Board of Registered Nursing. So this was published in a nursing edition of Professional Counselor magazine as an attitude survey and presented by me at the National Nurses Society on Addictions conference in 1982. I'd like to report success. However, because the Board of Registered Nurses' primary objective is public safety, they insisted on having reports of relapse, forcing nurses to go underground if they had continuing problems and shutting them off from help for relapse. The second thing I did, working in a detox and rehab facility, the doctors practicing there wanted to know if a new medication at that time, Halcyon, would be better than the medication we were using at that time, Restoril. We were also using still chloral hydrate at that time, an older sleeping medication. So this is a two-group head-to-head study, randomly assigned, so it's a valid study. There was no placebo group, and we found no significance between groups, so physicians were free to choose, their preferred drug, often based on what they're told by drug detail people that come to the office to encourage use of their particular brands. The next project I was involved in was in the certification of nurses in the field of chemical dependency, and we were developing as a group an exam to identify nurses that had special expertise in chemical dependency. So that group A was a group of nurses recruited from a local hospital who had no significant experience treating chemical dependency. Group B is a group of nurses that had 2 or more years experience in chemical dependency. And when we got the results back, the exam did discriminate between the two groups, and we determined a cutoff score, that is, the minimum that one would have to score to pass the exam and be recognized as a certified or credentialed chemical dependency nurse. The next project I did in my National Guard unit, we had the group of poorly motivated soldiers, and some of us felt that the leadership wasn't motivating people correctly, so I did a survey. It's always good to get data, and sure enough, medical soldiers felt poorly motivated, However, sometimes when you do research, it goes for naught. There are no changes made as a result of this survey determining poor motivation. I went to work at VA West LA in 1994. VA West LA had a research budget of $100 million a year for many types of research. My first task was to downsize a 40-bed single diagnosis alcohol drug unit on the top floor of this building into a 20-bed unit and start a 20-bed day treatment program, which I had experience with. When I completed the downsizing, then they decided to move the dual diagnosis treatment program that did do some medical research into this area. So I also inherited a program that did research. Some research, not all of the research done at VA West LA, including long-acting morphine. You may know that methadone is a short-acting medication, and this would allow people who are on maintenance programs to come in less frequently for their drugs. Also, buprenorphine, now known as Subutex, was developed there for a detox drug, and when combined with naloxone, the opiate blocker, that's a popular medication called Suboxone. Interesting research that was done there in the past, and some of the folks told me about it, was to determine effects of alcohol. And in this program, not done while I was there, every patient that had agreed to the research was given a fifth. The fifth means a fifth of a gallon or less than a quart of alcohol every morning, and then researchers recorded the results on the unit. I transferred at a later date to schizophrenia research unit, an interesting unit that did medication development. So the nurses sometimes would give medications not knowing their name. They had codes, 24XYZ, HIBD, different coding, and the researchers would train us as to the potential side effects for all the medications, and there were protocols in place that if there were any untoward effects, then the researchers would break the blinding and let us know so we could take emergency steps. That did not happen, but it was always interesting to know and learn from the researchers. During the time I was there, Consta, that's the long-acting risperidone, antipsychotic was developed. Long-acting antipsychotics have helped us tremendously in the mental health field where compliance is a major problem. Also developed there at that time was Abilify, known as aripiprazole then, which is primarily developed for an antipsychotic, but found to have antidepressant features. Sometime before I was there, Clozaril was also developed there and at other clinical sites, which was the first of the second generation atypical antipsychotics. That research unit moved to the main hospital, and I was able to assist in the design, along with the psychiatrists, a research unit in the main building, which is still in operation, as the MyRec Treatment Unit, Mental Illness Research, Education, and Clinical Center. Also during this time, I was appointed to the IRB, Institutional Review Board. You'll find out more about the function of IRB in my class. And the reason I was appointed was a major incident that had occurred at the medical center, causing the suspension of all research and the suspension of that $100 million I talked about earlier. What had happened was a cardiac surgeon was doing research on a cardiac procedure. A veteran patient had signed agreement to have the experimental surgery, And on the way, on his gurney from his room to the operating room, he said he did not want the surgery. The surgeon went ahead and performed the surgery, and it caused major problems all the way up to the Washington, D.C., and the Committee on Veterans Affairs. And that is why I was appointed to the IRB. And we had extensive training on protections for human subjects, and I functioned on the human subject subcommittee of that IRB until I left there for VA Long Beach. At VA Long Beach, we did studies on peer support. Actually, one of the researchers kind of followed me down there, but they did research at several sites. So MICM was supervising a program at that time that's psychiatric, home health, and community care called Mental Health Intensive Case Management. And in this study, they wanted to find out if what is called peer support specialists would make a difference in treatment of mentally ill. Peer supports are people who have had their own problems with alcohol, drugs, or mental health, and become stabilized and then wish to help others. And this may be a pathway to advanced degrees and more training in counseling, nursing, social work. So our site was a treatment site. We received additional peer support staff, and the control sites received no additional staff. The outcome was that the treatment sites had better patient outcomes. Now, this doesn't really say that they wouldn't have had better outcomes also if they would have had 2 extra nursing staff or 2 extra psychology staff or 2 extra social work staff or 2 extra nursing assistants. So, but the study showed a positive effect of peer support, and that's widely used in mental health now. After I'd left VA, I have done a little bit of work in Arizona. The first thing I did is called In Search of a Smart Personality. I've been a volunteer worker for what was originally called Rational Recovery and now called Smart Recovery, which is an alternative to the 12-step support group in the community. The original hypothesis was that participants in this program, which is cognitively oriented, would be more attracted to this type of program. So I wanted to test that initial hypothesis. So I did get volunteers to take the Keirsey personality test to measure the thinking versus feeling personality styles to try to answer this hypothesis. The results, unfortunately, did not prove the initial hypothesis. Actually found that 67%, 50% is the mean or average, were feeling type, emotionally motivated people, while only 33% were cognitively oriented or thinking types. And here is the data table for that research. Having worked with the Joint Commission several times during my last Joint Commission survey at the Guidance Center, I had some discussions about the usefulness of nursing care planning with the nurse consultant in the Joint Commission survey. So I decided to collect more information. So I collected information from 100 nurses. I solicited input from survey input from Flagstaff Medical Center, the Guidance Center, and some nursing-oriented websites. I easily got 100 responses, and I asked only for experienced nurses. Here are the results. This survey was done with a Likert scale. 5 is agreed most, 1 agreed least. And the most frequently responded to and highest rated was nurses feeling the time taken to write patient care plans takes them away from bedside patient care. I had this experience myself going to work after my retirement from the Department of Veterans Affairs in a private home health agency doing psychiatric home health, and found that half of my time was spent at a computer. And I went to my new supervisor within a few weeks and said, I don't think this job's for me. I did not go to nursing school to type on a computer. I went to nursing school to learn to help patients. Secondly, experienced nurses feel that they can effectively plan and deliver care without detailed written care plans. These have become a perfunctory duty. And look down at the bottom while we're discussing this. Nurses say they don't look at the care plan ever. It's written at admission and closed off at discharge, and really is not of much use. Nurses feel the third line, 3.98, that the requirements complicated the nursing planning process. Nursing should not let other agencies dictate or determine for us what the nursing process is. We as nurses should make those decisions. The active nurses did feel that written care plans are helpful for nursing students because that helps students learn the nursing process. And fifthly, the use of nursing diagnosis does not seem too important, and I hear that we're finally going to phase out the use of the nursing diagnosis. I've instructed these classes before, starting after my retirement from the VA. I've taught in the graduate program one class in evidence-based practice, and this course, 390W, several times. I also teach psych mental health clinical in both the accelerated program and the traditional program. So if you have questions, feel free to contact me. And I hope you enjoyed this presentation.